little bit about modern orthopedic approaches and some other orthodontic approaches, so-called extra-alveolar movement, which is a tremendous amount of movement using TADS. And finally, but last but not the least, I'm going to talk about biomechanics of intermaxillary mechanics, especially on class 3 particularly. I believe everybody in this room will recognize this famous photo or artwork from Velázquez. And you can look up the internet so that there are many mysteries behind this picture. So you can see a very interesting story behind this. And here we have a little princess over here. Her name is Margareta. And the artist this one himself is Velázquez, and she's drawing of her. And her parents is sitting behind somewhere over here, so they are reflecting over the mirror. So if you carefully look at them, these are the parents of this Princess Margareta. And who knows, who have anticipated that now, after growing up, she became like this class 3. So in the Spanish royal family, they married between very close relatives, so that they all have a class 3 tendency. So it's a definite evidence of class 3 is hereditary. Okay? So it's not possible nowadays, but for sometime in the near future, we can do a gene therapy because it is genetic. So but for now, it's not that successful. So how much of class 3 do we have? One of the studies shows that in Asian, like Korea and Vietnam, there are quite many class 3 than Western countries. So in Caucasian, its prevalence is about 1 to 4.5% of the population. And we have much more class 3 in Asian people. So let's start with non-surgical treatment planning. So here we have a problem of non-surgical treatment. Why is class 3 difficult? Because unlike class 2, for class 2, instantly you can protrude the mandible and make the appearance better instantly. However, in class 3, that's not possible, and aesthetically, it is very difficult to treat. The reason is we are treating against the direction of the growth. So that's why class 3 treatment makes it very difficult. And what makes the situation more worse is that the result is not that stable. So it makes many factors are involving in making the class 3 treatment very difficult in nature. Here is the skull of Old Glory of Dr. Engel, and he classified malocclusion into class 1, 2, and 3 based on the relationship of the molar. So it is very simple and very easy to understand. However, the classification is only horizontal relationship is based on the horizontal relationship of the molars. Nevertheless, they have many subdivision cases involving asymmetries, but basically Engel's classification is just a horizontal relationship, and it does not account for any vertical problems here. So if you take a look at the cluster study of Thompson and Simpson, we can see that in many class 3 slight mandibular prognathism, there are many percentage of reduced vertical here and increased vertical, and there are the majority of about 1/3 of them are purely mandibular prognathism. So the class 3 is not only a horizontal problem, many problems are associated with together, so that it makes the diagnosis quite complicated. So when we diagnose class 3, first one that we have to look at it is skeletal and dental, and most of all, we have to look at the soft tissue facial, because patient is concerning about their appearance, not the skeleton inside the skin. So we have to carefully look at the soft tissue facial analysis. And also, there are many functional problems too, so-called pseudo class 3, habitually, if the patient is protruding the mandible, it is diagnosed as a functional. In other words, you can call it a functional shift. And another interesting topic would be growth pattern. How can we predict the growth? If this gonna, as we see at the first slide, who have expected that little Princess Margareta become a severe class 3 later on? So can we predict the growth pattern? That's another question that we're going to ask, and we're going to get the answer. Let's start with skeletal. In terms of skeletal, although the vertical and horizontal skeletal seems to be a different area of interest, however, the vertical and horizontals are very closely related to each other. So let's take an example over here. So here we have a so-called class 1 molar, straight profile. Okay, but if the mandible is to be hinged close, not only vertical changes, but also facial convexity becomes straight and become concave by hinged mandible close. In the opposite direction, if the mandible is hinged open, we'll have a more convex profile. It's because hinge open does not mean only vertical problem, but it also moves the mandible backwards. So the movement of the mandibles are combined movement of vertical and horizontal at the same time. So I would like to propose the classification of class 3, not as class 1, 2, 3. I would say facial concavity type and facial convexity type. And these are the two different aspects of approaching the treatment and diagnosis of class 3. So let's take a look at the clinical case. Here we have a class 3 relationship. These are the two different patients. Here we have a class 3 molar relationship and underbite here. And also this patient shows class 3. So in Engel's classification, they are both class 3 horizontal problem. Okay? So it looks like very similar. But if you take a look at the X-ray, this is the one at the left and this is the one at the right. So I would say this is a convex type of class 3, and this one would be concave type of class 3. So what would be the difference? How do we approach them? If you take a look at the facial convexity, we can see that the face is straight to convex. And on the right side, definitely the patient shows concavity of the face. So what are the characteristics of them? In facial convexity type, there are steep occlusal plane, okay? And vertical is increased, and gonial angle is increased, and we see that the mandibular plane is increased. On the other hand, it depends on the area involved. However, there is a deficient growth of maxilla in concavity type, and there is an excessive mandibular growth, and sometimes it is associated with deficient premaxillary growth and can be combined together. And sometimes it can be sometimes it is associated with vertical excess or vertical deficiency. Both can be involved. And let's take a look how we make a decision, how we set up a treatment plan. Here's the first case. We see that there is a definite class 3 molar relationship and cuspid relationship. And if you take a look at the X-ray, here's the X-ray and board. The patient is not concerning about the skeletal relation, and patient is concerned about their face. And if you look at their patient's face, it looks quite straight, or even it can be convex, right? So if you take a look at the profile seems to be very nice. It's not that severe class 3 case, right? So if you see, only look at the model and plan the surgical plan like this, you can, for decompensation, we extract the upper and set back the mandible, you can make the facial appearance much worse. So this kind of facial appearance should be first priority in deciding approach, whether you do it surgically or not. So I'll recommend that it is definitely not surgery. And if you have done the surgery, definitely he might have made a genioplastic advancement, right? So I don't think it's a good choice to treat this patient with surgical approach. Let's take another case of the right concavity type. As you can see here, the patient showing, if you see at the intraoral photo or the model, it definitely shows class 3 relationship. And you can see that the mandible is in excess. And another characteristic is that he has a redundant lip. So his nasolabial is reduced. So he shows quite lower facial height reduced than the normal. So if you make a setup a surgical plan to set back the mandible, you'll have a much better profile. But let's take a look if there is a horizontal problem here. So here is the patient before, and here's the patient after. Do you think we had a surgery? No. I just open up the space and let the patient be in a physiology rest position. He just opened up the space a little bit, like 3 or 4 millimeter in premolar area. So you can see the mandible hinge open and profile instantly enhanced by only vertical problem. So if you only hinge the mandible open, not only you have an increased vertical, but also you have a effect of setting back the mandible. So this patient is more than a vertical problem than the horizontal problem. So you have to see the criteria for selection of the treatment should be based on facial convexity and facial convexity. Okay? So let's take another example of facial concavity type. Here we have a little girl. To begin with, she has a congenitally missing upper premolar here. So only one premolar is present in the upper, and the lower shows a little bit crowding. And here we have an underjet here. So if you take a look at the face shows a little bit concave type here. So what we need is to hinge the mandible open a little bit. So here's the patient to begin with. Here's the face. And as upper is already missing, I extracted the lower thigh and retract the lower incisors. And let the tooth rubs a little bit. So later we have a positive overjet here. And here's the end of the treatment. And if you have a superposition, you see that the mandible has been hinged open a little bit. Normally, the mandible is growing along the y-axis, so the mandible has been opened a little bit by extrusive mechanics. So this horizontal problem was partly corrected by not only by horizontal movement of the tooth, but also the vertical mandible hinge open played a big role in treatment of this patient. Let's take another patient for upper incisor proclamation. Here we have a cleft lip patient here. So here we have a premaxilla is deficient here. But look at the profile. Although he is showing class 3 incisors and molar relationship, his profile is not that bad. So what I need to do is procline the upper incisors and hinge the mandible open a little bit, because the patient's profile is straight to concave a little bit. So here's the patient before. I expand a little bit, correct the upper crossbite using the lingual arch, and expand the upper. I open up the space within a spring, and upper was moved to the forward. Okay, so here's the patient after the treatment. The patient's profile shows a little bit more convex before the treatment. And let's compare the X-ray. It shows that mandible has been hinged open. Okay, so mandible has been hinged open, and the TRIS 3 was treated by hinged mandible open and proclination of upper incisors. Let's take a look at how dental problems are considered in class 3 correction. There are very special cases, so that it says dental masking, or sometimes it is called compensation. Okay? The compensation occur in many ways. The tooth itself can be compensated. The skeletal and dental inclination can be compensated at the same time. So let's take a look at first compensation. Here is, you can see the patient. Does this patient shows class 3 or programming mandible? I don't think so. His incisor is edge to edge, and profile seems to be quite straight. But if you let the patient oriented to the natural SN minus 7 degree horizontal plane, you can see the mandible is very moved forward. And as you can see, the angle of the incisors is heading behind the sella. So incisor is severely compensated. So even if this patient does not show severe class 3, actually it is compensated so that this patient perhaps needs surgery. Okay? So this patient will prevent the surgery, even though it doesn't show too much class 3 relationship. This patient not only shows class 3, but also a little bit of an asymmetry here. Class 3 is more severe on his right side. So here is the upper and lower. Asymmetry is not that prominent in the facial field, however, his midline is deviated by 3 or 4 millimeter. And facial profile seems straight and pretty normal, right? So in this case, the important thing is to keep the compensation or make the compensation more to correct this by non-surgical approach. So here is the patient before, and what we need to do is bring the upper teeth to the left side and move the teeth to the left side. So I need to keep the angulation of this, or even I tip it more backwards. So here's the patient after the treatment here by compensation. So you can see the patient has been leaning, the lower teeth are leaning to the right side a little bit, even though the midline is corrected. You can see the molar and these buccal segments are tipped forward, and incisors are leaning to the right side by compensation. So the decision criteria is based on facial profile, not the skeletal pattern or dental problem, right? So this is a patient after the treatment. And another thing that we can see is a so-called column angle. It was first appeared in the paper back in early 1990s. And I don't know why it's called, but it's called column angle. It's an angulation between crown and the root. So sometimes it is normally the column angle is straight, but sometimes the upper teeth shows some kind of an angle like this. It has a severe column angle. It's not an anomaly, but just an aberration or normal deviation, I could say. So the tooth might look very lingual intact, however, it has a normal angulation. So this kind of a column angle should be considered when we diagnose the patient. In this patient, we see the pretty normal profile, right? However, if you take a look at the patient, he has an overjet, underjet here, and you can see the column angle the tooth is bent over here. So it looks like it is lingually inclined. However, the actual average overall angulation is normal. So once again, the most important criteria for diagnostic factor would be soft tissue facial. So this is the most important. As we've seen before, this is a patient that needs mandible hinge open, and in this case, pretty normal face. So don't make mistake to make a surgery in this kind of patient. And in this patient, you might think that it can be treated non-surgically. However, it is compensated. so then you definitely need a surgery. So these facial profile is very important to decide which approach should we use. And in correction of class 3, the function is very important too. Examining the function is only during clinical examination. You cannot do functional analysis by records, X-ray or model or any other thing does not give you any evidence of functional discrepancy. So you have to do carefully in clinical examination to have functional problem the patient has. One of the common functional problem would be COCR discrepancy. In so-called in growing patients, some patients are showing pseudo class 3, habitually through the mandible. But it looks like a definite skeletal class 3, but it's just inhabitual and functional. So if you correct the function, you'll correct the class 3, and you should differential diagnosis this shift. And in functional, there should be another vertical problem, so-called freeway space. The interocclusal space is too much. We can have a room for extrusion so that the treatment result will be stable. But if you don't have enough interocclusal space, the stability will not happen. So the important thing is that this functional analysis should be done in the clinic during clinical examination. Let's take a look at this patient. Here we have a class 3 molar relationship. There's it over here. And profile seems to be a little bit straight, although it looks like bilateral protrusion though. So here we have a tracing. You can see that there's a definite class 3 relationship. And fortunately, we have well-erupted third molar in the lower. That means we can do uni-arch extraction of the lower only, like unilateral uni-arch extraction in class 2 case. For class 3 correction, unilateral extraction of the lower should be performed only when you have an intact third molar. If you don't have a third molar erupted, if you extract the lower only, the upper second molar does not have the antagonist, lost the antagonist, so that it's going to erupt, and it could be very problematic later on. So, fortunate for this patient have a class third molar, so I extract the lower premolar only. Here's the patient before. This is a third molar. Facial photo. And only lower premolar was extracted and tracked. So here is the patient after the treatment. You see that the complete class 3 molar relationship. Conclusion has not been settled yet. It's just right after the debonding, so it's going to be settled later on. And here's the patient after the treatment of lower uni-arch extraction. And what caused the treatment? Here's the tracing over here. And here's the before. And superimposition shows when we let the molar move forward a little bit, we can move the mandible shift to the backwards a little bit. So partly, not only the incisor was retracted, but you can see the mandible has been hinged open, and more importantly, here we have an articulary here showing that the mandible has been shifted backwards. So this patient used to have a COCR discrepancy, however, he could not retract the mandible because of the good occlusion to begin with. So if the lower molars are let the lower molar move forward, we can move the mandible backward a little bit. So this kind of hinge, mandible shift is plays very important role in correction of class 3. So how can we evaluate the mandibular shift? You can see the articular issues. And finally, growth pattern.
Xét đến cái chỉ tăng trưởng của bệnh nhân,
Is there any particular class 3 growth pattern?
có một cái chỉ tăng trưởng gọi là chỉ tăng
Well,
trưởng ba hay không?
Skeeler and Bjork suggest that class 3 patients shows certain characteristic of class 3 development. And Sassoon argued that the musculature influence the future growth of the bone. However, these have been not definitely proven yet. So we're just looking at the one X-ray and predict how she or he gonna be developed class 3. It's quite questionable for now. So as a summary, what would be the modality of class 3 growing patient treatment? First thing we can consider is growth modification of orthopedic treatment. So we can enhance the maxillary growth, or we can inhibit the mandibular growth. And the second is obviously we can what we do daily, using moving the tooth within alveolar bone boundary, or by using a TAD. I will talk about it in the later part of this session, when you can do extra alveolar movement. And also we can, as I talked before, we can do mandible hinge open, in other words, mandible rotation, and mandible shift also plays a very big role in perfection class 3. So the selection criteria, the first priority should be put on facial aesthetic, as I told you before. Patients concerning about their facial appearance, not the relationship of the molar. He doesn't care if it's class 1 or class 3. The most important criteria of the facial aesthetics. And another factor we should consider is AB to occlusal plane. This is in the classical term, it's Witt's appliance. It is a perpendicular line drawn to the occlusal plane from A point and B point. I'll show you a little bit later in this next slide. And also in class 3, as I said, we are moving the teeth against the direction of the growth, so stability is very important. So let's take a look at this young gentleman here. It's a transfer case. It's a 16-year-old boy. He's a transfer patient, and the former orthodontist wanted to do a surgery for him. So this first premolar is to be extracted and decompensate for contracting the upper, and the patient is going to have a setback treatment was planned. And here we have a lateral sample here. And if you take a look at the profile, I don't think this patient, I thought I could approach it with this orthodontic approach because facial appearance was not that bad. So I told his parent that let me try it with a surgical approach. So here's the patient before and after. And I'll tell you at the later part of the biomechanics on Intermex cardiovascular. I put the elastic somewhere over here, not at the most anterior part. I moved the elastic a little bit distally, near the area of premolar, I could say, and I could hinge the mandibular toes. And here's the patient to begin with. So the patient shows class 3 with open bite. And unfortunately, the patient shows a little bit of occlusal plane canting. Right side is positioned upwards and left side downwards. And also the midline shift is over here. So what I did was to put some crisscross elastic over here so that I can correct the midline and correct the cant of occlusal plane at the same time. So this is a patient to begin with, and during the treatment and after the treatment. You can see that the occlusal plane has been moved. I'll talk about it in biomechanics section. And not only midline is corrected, overbite was increased, and also the occlusal plane was synchronously rotated counterclockwise for this patient. And is the result stable? Well, I hope so. For now, up to now, it's stable. So once again, we have to look at the facial appearance for the diagnosis, not the skeletal relationship. So we do lots of cephalometric analysis, and many analysis showing if you have certain amount of number, it indicates extraction, and if you have some kind of very complicated analysis, and then if the results showing you that this patient is class 3 surgery, but do not rely too much on the numbers of the cephalometric analysis. Most important factor to consider is facial appearance. Once again, so here is a superimposition. You see that the upper and lower occlusal plane has been pushed together. There is no mandibular rotation, but you can see a little bit of shift. And AB to occlusal plane. This is AB to occlusal plane. Here's an A point and B point, and draw the perpendicular line to the occlusal plane. And the discrepancy over here is AB discrepancy on occlusal plane. And in some literature, it is called Witt's appraisal, right? So what will happen? A point and B point are stationary, does not move. But let's suppose we move the occlusal, rotate the occlusal plane. So if we stiffen the occlusal plane, we'll get the problem worse. Okay? So to correct this, there are lots of root movements required. So if you stiffen the occlusal plane, the AB relationship becomes worse. Even though the A point and B point did not move, the relationship is changing just by changing the occlusal plane. If the occlusal plane gets flattens, it's going to help correcting the class 3. It becomes class 2, right? So even if the A point, we are not moving the A point and B point, we can move the occlusal plane to correct the relationship according to occlusal plane, just by changing the occlusal plane. Let's take a look at this patient. This patient shows traumatic mandible. And I don't know if he had a previous orthodontic treatment, but there's a severe decalcification, but it's not today's interest here. And you can see the class 3 relationship of molar and cuspid over here. And this is the patient after the treatment. What I did was extract upper and lower premolar and no-term use of class 3 lessons. And you see that we have a dramatic change of the profile only by using extraction. This class 3 becomes class 1. And let's see how occlusal plane changed. This is the patient to begin with, and here's the patient after the treatment. See, this occlusal plane over here is here, and we put class 3 elastic like this. So I'll talk about it in the biomechanics section, but on the upper, the force is acting below the center of resistance of upper dentition, so that not only it moves backwards, but also it's going to rotate, it's going to, oh, I'm sorry, class 3 elastic is like this, right? So upper occlusal plane is going to be flattened, and the lower occlusal plane will be flattened at the same time. So let's see what happens. If you take a superimposition, this black line is the patient before treatment, and the red line is the patient after the treatment. So actually, A point and B point did not move at all. However, the relationship between improved only by changing the occlusal plane. So if you take a closer look at it, you can see there are a severe amount of anchorage loss in the upper, and lower incisors are retracted orthodontically. And this is the relationship of AB with appraisal. The discrepancy has been reduced this much just by changing the occlusal plane. Now let's talk about the stability of the treatment. Here is a famous research from Taggart, English orthodontist. He used 15 male and 13 growing patient female. And he used non-extraction techniques. he used nothing but class 3 elastics. And let's see what happened. As class 3, the lesion is as it is a growing patient. You can see that the maxilla is being rolled forward. And you can see that the occlusal plane has been flattened on class 3 elastic. A little bit of mandibular shift. And also, the mandible has been hinged open a little bit because normally it has to grow along the y-axis. You can see that the mandible has been grown up. It has been rotated backwards a little bit, both in male and female. And this is 2 or more years after the post-retention. You can see that the mandible has been hinged closed again. In other words, it relaxed a little bit. However, when it relaxed, the important thing is the occlusion. If you take a look at the normal growth of the mandible, if mandible normally grow much more than a maxilla, right? So then it's not a topic for today, but let's suppose we have class 2 patient, growing patient, and let the patient grow normally, and will the class 2 correct normally? No, it doesn't. But if you use the activator or functional appliance so that we can protrude the mandible and let the mandible move forward using a functional appliance, sometimes it's going to correct the class 2. What is the mechanism? Does the class 2 activator enhance the growth of the mandible? Perhaps yes. But more importantly, the functional appliance discludes so that the occlusion is discluded. So the interference has been eliminated. That means when mandible grows forward by the intercuspation, as mandible grows forward, it pulls upper dentition forward at the same time. So occlusion is very important in class 2. So disclosing the occlusion is very important in class 2 correction. Same is in class 3. If we have a sufficient overjet or an overbite after the treatment, as the mandible relax or grow forward again, it's going to pull the all upper dentition forward together. So it is very important to have a sufficient overjet overbite after the treatment. So this is a typical relapse pattern and treatment result of class 3 elastics. Let's take a look at this patient here. This young lady, 9-year-old, appeared to me, and she has a severely impacted upper cuspid over here. And CT shows it starts to resorb the roots of the leg. So I decided to remove the cuspid. Okay? So at the age of 9, as you can see that the X-ray, we can see over here, even though she shows class 3 relationship, facial profile is somewhat straight. Right? As you can see, the upper face and lower face ratio, you can see that the lower face is quite deficient. Small lower facial height, actually. But at the same time, the corneal angle is quite increased. That's the skeletal trait of this patient. But what I put more emphasis on the facial profile. The facial profile has a straight to a little bit convex, even though she shows class 3. So this is the patient to begin with at the age of 9. Okay. So I extracted the and kept waiting. And I did nothing. Okay, so this is a 10-year-old. And 13-year-old, I did nothing but wait and see. And let's see what happens. You can see that the nasion has been brought forward a little bit from the later. Normally, the amount of maxillary moving forward is the same amount of nasion. You can see that the nasion has been, the A-point has been brought forward like 3 or 4 millimeter. And if I say I use protraction head here, you might have to believe it. But this is not true. I did nothing, just kept waiting. And this is a normal growth, the forward growth of the maxilla. Okay, this is molar growth. And then we look at the amount of mandible growth over here. So you can see huge mandibular growth over here, and in superimposition, mandible has been grown along y-axis, and the maxilla has been moved forward. So I started treatment at the age of 13. So I extract the lower and extract incisors and use class 3 elastic block to rub the teeth so that I hinge the mandible over. Okay? So here's the patient after 2 years of treatment. She at the age of 15. And you can see that mandible has been opened a lot because it has been hinged open. And most of all, you can see that here is a large amount of mandibular shift, about 2 to 3 millimeter. So not only it looks like a skeletal orthopedic effect, but however, it's just a repositioning of the mandible backwards. So important thing is that at the age of 15 or 16, normally the girls ended their growth at the age of 16. So it's good to wait until the growth ceases. So I think by considering her age, this is resulting to be stable afterwards because she does not grow from that. Here's a forward growth of the maxilla. It's just a normal growth. I did nothing. And mandibular plane has been flattened. So the flattening, the rotation of the mandibular plane played a great role in correction of plastic. Also in the lower, you can see the huge amount of mandibular growth was offered here. And her facial profile, even though it has been open, facial profile has been improved a lot. And considering her age, the result will be stable. So the rationale of class 3 treatment would be rotating the mandible movement, okay, and flattening the occlusal plane, and moving the upper teeth forward, lower teeth backwards, and perhaps a little bit of orthopedic effect. So let's take a look at the non-extraction versus extraction. For non-extraction case, we use a lot of intermaxillary mechanics so that AP-incisor relationship is changed. And the arch length discrepancy determines the extraction. If we have a severe arch length discrepancy, there's going to be an extraction. And in non-extraction case, most of the treatment is done by rotation of occlusal plane. But in extraction case, we do use the intra-arch mechanic so that there will be a little amount of rotation of the occlusal plane. So the only horizontal movement should correct the AP relationship of the molar or the incisor. Let's take a look at the patient with arch length discrepancy with intraoral mechanic was used. Here we have a class 3. Molar relationship was pretty normal. However, his profile shows class 3. And here we have underjet. So what I did was to extract the upper and lower and move the tooth only horizontally. There is no vertical movement involved here, so there's only horizontal movement to correct class 3. So this is a typical case of extraction case without mandible being open or rotation of the occlusal plane. Now let's move on to orthopedic effect. Well, what we have been done for orthopedic effect, I would like to ask ourselves 2 questions, and the rest of my presentation will be the quest of answering this question. Now, is it possible to retard the mandibular growth by force? Or can we enhance the maxillary growth by protraction headgear or something? Is it possible or not? If possible, then how much can we enhance the growth and how much we can retard the growth? That would be the question. And is it the result of a real orthopedic defect.
là kết quả của một sự chỉnh xương thật
Up
sự
to 1986, if this is an official journal of American Association of Orthodontists. Up to 1986, the name of the journal was American Journal of Orthodontics. Nowadays, after 1986, the name of title of the journal has been changed to American Journal of Orthodontics and Dental Facial Orthopedics. Okay? So we want to deal with orthopedic defects. One of the most certain results of orthopedic defect would be traditional rapid palatal expander. If we expand, there will be a gap between, open up the suture, and there will be a growth in the gap between here. So definitely this is an orthopedic defect. So we can modify the growth of the bone. In old China, I don't know why they do this, but there is a custom of foot binding. This is a normal foot of the woman, and this is the adult feet fitting into this small shoes here. If you take the X-ray, they wear this kind of a straining shoes when the girl is very young, and kept this wearing for grown up. So you can, if you see the X-ray, his bone is deformed and the feet very small. I don't know why they did it, but this is another evidence showing that we can modify the growth intentionally. And in some countries, as you can see here, they restrict the growth of the forehead so that if you take an X-ray, we can definitely modify the growth of the cranium, and it shows that we can modify the growth. So, in modern society, the approach of the modifying the one of the oldest orthopedic approach is the chin cut. So can we retard or restrict the growth of the mandible? So the mechanism would be condylar growth modification, and sometimes we can modify the growth of the ramus. If you take historically, if you take a photo, I took it from the Angle School, and it shows Angle used the chin cup over here to treat this foot-napping mandible. And as we all know, Angle was a great believer of the Dr. Wolf, who was a German physiologist and anatomist. He finds that the tropicalization pattern is formed according to the force trajectory of the stress in the femurs. So what he believed that the shape of the bone is modified by the stress acting upon it. And Angle was an enthusiastic follower of this Dr. Wolf. So what he think was he can malleable the bone to any shape if we apply the force. That's why he was stick to non-extraction. So if he expand, the bone will always follow because he believed that the bone is malleable, so he can modify it. So that's why he insists on extraction case. Sugawara and his colleague did a long-term chin cup therapy, and he was trying to find out when to start the chin cup therapy. And here he collected 500 cross-sectional samples here, and here is a non-treated girl, observed from 7 to grown up, 7, 9, 11, 14, and 19 years of age. And cross-sectional model is composed of 100 patients each group. Okay. So this is a normal growth. Here we have a growth from 7 to 9. You can see that nasal is being moved forward a little bit, and as much as nasal grow, 8 point moves forward. And you can see that the upper incisors are move forward because normally mandible grow more than the maxilla, and it pulls all the dentition forward together so that upper incisors leaning forward and mandible is growing along the y-axis like this. This is the amount of normal growth for 2 years. And one group was treated. The treatment began at the age of 7, and 2 years of chin cup was applied. And let's see what happened. You can see that the nasal has been grown, acoid has been moved forward, and the crossbite has been corrected. You can see that the upper incisors are leaning backwards by the force from the chin cup over here. And what else is done? You can see that the mandible has hinged open. So a lot of treatment was done by mandible hinge open. Okay? And also here we have a shift of the mandible also. So this is the amount of treatment of 7 to 9. And this case was the same case. Treated began at the age of 9. Is it good to treat the patient at 7 or 9 compared? So at the age of 9, he said a similar result. The mandible has been hinged open. And the result is that even though you treated the patient at the 7 or at 9, here is the patient begin at the 7 and observe at the age of 11. You see that if the patient was treated earlier, definitely there's a much greater orthopedic, it shows a greater orthopedic effect. However, if we observe the patient at the age of 17, here's the control, and this group from this treatment group started from age 7, and the patient started at 11 shows not significant different from each other. That means the timing of treatments is not that important. It gives a similar result afterwards. And here's another famous chin cup study from Dr. Mitani, Japan. And he concluded that chin cup, he did a humongous research on chin cup for 40 years, all over his life. And he concluded that chin cup therapy is to be used only as an option. Okay? It does not retract the mandible effectively, and only limited to mild to moderate case. And if the mandible is case, it is contraindicated for not using chin cup, because eventually it happens to be skeletal, the surgical case. So in severe mandibular progressivism, it is contraindicated. And a few years later, he showed very interesting chin cup twin study. Here we have sister A and B. They are identical twins. Okay. So on sister A, she received a chin cup therapy, and sister B, I'm sorry. In sister A, it's a control, did nothing, no treatment. On sister B, she received chin cup therapy and observed after 2 years. After 2 years, the control sister A shows no change, overbite. And the chin cup therapy data was done on sister B, showing that the interrelationship has been improved. And she was followed up after grown up, okay, at the age of 20. And here's sister A and sister B. And there's no change. Here it was stable, the result was stable. And what interesting is was there an orthopedic effect? And by the superimposition of the mandible from sister A and B, it shows that skeletally they have the same amount of growth. So chin cup has been fitted to modify the growth. But interesting thing is that we can see that mandibular incisor has been moved like translation, right? It's very difficult orthodontically to translate the mandible backwards. But what I can be pointed out at this point is that when you apply the chin cup, the force is not a single force applied, not the force applied at the point, but the chin cup is like a distributed force. So the force is acting along here, so that the force is quite near the center of resistance, so that it might help to translate the lower incisor backwards. So as a conclusion, in chin cup therapy, the orthopedic effect was quite minimal. So what is the skeletal effect of chin cup? Well, perhaps a little bit retardation, maybe it will decrease the growth of the mandible, maybe, and maybe it's gonna decrease the bony angle. in condylar flexation. We can flex the condyle. But most of all, the mechanism of the chin cup therapy would be mandibular rotation and mandibular shift, not the pure orthopedic effect. And let's see if we can modify the remodeling of the ramus. There is a famous study, the PEAK study. You can see that there is it's done by Humphrey a long time ago. And this is a growing pig, so that there are two wires, the anterior wire over here and the posterior wire over here. And later on, you can see that the anterior wire is lost. So here we have a bone resorption of the anterior border, and classical term in classical study, there's a bone opposition in the distal part of the ramus. So is it opposition on the surface, or is there interstitial growth? To find out, we can see that the Bjork's implant study, he put the implants in the inside of the bone. I think he did it on his children, to put the implants on the mandible and see what happened. And he found out that the distance between these implants inside the bone does not change. So there is no interstitial growth normally. Okay? So most of the time when we use a chin cup, it's going to make the pinch open and it's going to retract the mandible. Let's suppose, can we modify the chin cup so that we can hinge close the mandible? Well, if we close the mandible, hinge close the mandible, there are several methods to do it, like the magnet, repelling magnets on the molar areas of the intrude. Nowadays, we can use tabs to intrude the molar to rotate it backwards, but let's not talk about the tabs for now. Some pump button or myofunctional therapy might be recommended to mandible hinge close. And there are many other good mechanics. However, we can take a look at this. Here we have a chin cup therapy. If you apply the chin cup, the force is acting at the condyle. The line of action is passing through the condyle, and it is to retract, it is to hinder the growth of the mandible. So this is the chin cup direction of the force for correction of class 3 chin cup therapy. And let's suppose here we have a center resistance of the upper and lower dentition. If you move the force anterior to the center of resistance, we can apply the force like this. So we can put the force vertically. So this is what he done. Lloyd Pierce, who passed away several years ago, but he's very famous on vertical chin cup therapy, and he tried to hinge mandible close by chin cup. So he showed a case over here showing severe open bite case, and mandible is hinged, and he tried to hinge to close the mandible by applying vertical force acting at the anterior to the center of resistance, like this. Force is applying this way. So here's the patient superimposition showing that the mandible has been modified, the growth of the mandible has been modified like this. And here's the case before, vertical. And here's the patient after the vertical chin cup therapy. I can see that when we present the case, we choose very extremely well treated case. So it's beyond the normal standard deviation. And I think personally, to modify the ramus or flexing this mandible is difficult. Maybe sometimes, but it's very difficult to generalize this idea. What about moving? What if we cannot inhibit the mandibular growth? Can we enhance the maxillary growth forward? Well, we have many evidence that we can lengthen the bone. In some tribes, if you take an X-ray of them, you can see that actual length of the bone is not increased, and the intervertebral disc space has not been increased. Rather than that, the clavicle and the rib cage has been deformed a little bit. So I don't think it is an actual lengthening of the bone, but just a directional modification. As I said before, to make an interstitial growth, there should be a suture. it is very difficult, or I'd say it's impossible to make interstitial growth by force. So if we can to make an interstitial growth, if there's no suture, we have to make a suture. Okay? So as we know, this is Elizarov apparatus, so-called distraction or osteogenesis, which was used in microsomia to treat them. We can make an artificial suture, and we can make a new bone formation. This is the only way we can do an interstitial bone growth. So if there's no suture, there's no bone. Okay? So what if the suture is closed? So here is an interesting study of monkey, Dr. Kopich did. He used the monkey over here and put the titanium implant on the forehead and put the force on here. And the force was applied 24 hours a day, okay, 24/7, no rest period, even during feeding. And let's suppose the force level is about 1 to 2 kilograms on each side. Okay. Normally, when we do headgear or protection headgear, how much force do you use? Perhaps less than 500, right? But on the animal, well, ethnic committee won't allow this kind of spray nowadays, but it's quite a long time ago. So let's see what happens. So we can see that there's a definite growth enhancement in the maxilla. Teeth has been moved forward like this, about 10 millimeter, and 8 point has been moved forward. Okay? And sacrifice the monkey and see the suture. You can see the suture has been opened here by this kind of appliance. So definitely, in animal study, we have an orthopedic defect in animal study, right? And using a heavy force and making a suture. And you can see that there's a definite opening of the suture and new bone formation, and maxilla has definitely an orthopedic effect moving forward, right? But in human being, can we apply force 24 hours a day, like 1 kilogram or 2 kilograms per side? Well, if you have an experience, if the force is too high, you will have a soreness in the chin, and in severe case, mandible the lower incisor can show gingival recession if the force is too high. So I modified a little bit so that only chin cup is used instead of a forehead rest. I can do this way, the same effect. So this will be more comfortable. However, still, it's not possible to apply the force for 24 hours a day or very heavy force. Normally, the force is less than 500 in human. So here's an interesting study of Sugawara again. He used two-phase treatment on an identical twin. This is another twin study. So there is a patient 1 and 2, they are identical twin, okay? In patient 1, she received 9-year when treatment was done by 1 year, and after 1 year, the patient 1 shows A and B, show at the age of 9, patient A and B are identical twins, so there's no difference between twins, okay, identical twins. And after 1 year treatment, you see that patient A received the first phase treatment using protraction headgear, and you can see that compared to patient B, patient 2, which is a control, you can see that the mandible 8 point has been moved forward much more than the control for 1 year of protraction. So not only the tooth is being moved forward, you can see the maxilla the growth has been enhanced, okay, by protraction headgear, by 1 year treatment of protraction headgear. And at the age of 16, you can see that the upper teeth are moved forward, and you'll see the difference of the 8 point displacement here. And at the age of 20, you can see the whole effect has been, all effort we've been done was in vain. So this dental effect has been made, however, there is no skeletal difference between treatment group and the control group. So here's another study of Ishii. This is the patient with normal growth, and this is the pre-treatment, and this is the patient of the normal growth prediction. Okay? And he compared the treatment group and normal group and showed that in treatment group, ANS, A point, and the teeth are moved forward than the control group. This is the amount, this can be considered the effect of protraction headache. But as a conclusion, he concluded that most of the treatment was mandibular hinge open, mandibular rotation, right? It's not an orthopedic effect. And dental effect, the upper dentition is being forward, and most importantly, A-point has not been moved more than the normal group. So most of the correction was done by dental effect, not orthopedic. So Dr. Kokich was very curious if there's a but up to then, all the orthopedic appliance was applied in the teeth. Protraction headgear was applied in the teeth. So orthopedic effect it was very difficult to study solely on orthopedic effect because there is a combined dental effect and orthopedic effect. So what Dr. Kokich did was he was very curious about pure orthopedic effect. So what he done was he took an Apert disease patient and put the primary cuspid out and put it back again so that it is ankylosed, and protraction headgear was applied to the primary cuspid so that the effect is purely orthopedic. And what he found that the A-point has been moved forward about 4 millimeters. And you can see that ankylosed cuspid over here. This is before and after. And he concluded that pure orthopedic effect of this appliance in Apert syndrome disease is about 4 millimeters. But as we know, this is anecdotal one case, and Apert syndrome is characterized by early fusion of the sutures of the cranium, so that it is very difficult to extrapolate this kind of result to normal population. It's not a good idea to generalize this as a general conclusion. Right? So, what does protraction headgear do? Well, mostly it moves the dentition forward because the appliance is attached to the dentition, and lower dentition is moved backward by chisel, okay? And vertical is increased by mandibular rotation. And also, most importantly, there is a mandibular shift. And perhaps there's a little orthopedic effect in early stage. However, it turned out that it's not that stable. So let's take a look at normal growth here. As we know, in normal growth, as nasion grows forward, A-point grows the same amount of nasion. Okay? So normally, as nasion grows forward, the A-point grows a little bit, 0.3 millimeter more than nasion. Okay, so I could say the growth of the nasion the same as growth of the A-point. It's average amount of growth of the A-point. Okay. But if you took at the 3 standard deviation, there's an amount of 3 millimeter more growth of the A-point, even if just a normal growth is. Okay? And in 3 standard deviations, some patients shows less growth than the nasion normally, even if they are wearing a headgear. So this statement shows that there are a lot of variation in amount of growth of A-point. So it is very difficult to conclude that it is a pure orthopedic effect or it is just a normal variation. So it is very difficult to make a control group. But one thing for sure is that treatment should be used by developmental age. Here is an increment of AR Pogonium here, moving forward of a boy. So from the 5 years old, And you can see that in the group in age of here, we can see the peak of the aging, the chronological age. And if we use the developmental age again, you can see a definite peak over here at the growth spurt, which would be 14.5 years old averagely for boy. For the girl, it's 2 years earlier than this. And you can see that 32% increase of the mandibular growth. It shows that almost 5 millimeter a year. So in 1 year, normally it grows 5 millimeter forward. Okay? So, and also there is so important thing is using the growth spurt if you are expecting orthopedic effect in a short period of time. Now let's move on to the treatment modality using functional appliance. This is a Indian American native doing rain dance. Okay? During a drought season, they dance like this to pray for the rain. And a few weeks later, there will be a rain. So if they have a rain, that's because he did the rain dance. Okay? If he didn't do the rain dance, there will be no rain. Here we have a famous functional appliance, Franco. It's a Franco 3 appliance. It looks very complicated and it looks very uncomfortable, but as I get the feedback from the patient, it's quite comfortable once it is getting in. It's difficult to put it in, but once it is inside the mouth, they say it's better. There is a labial shield over here. There is a shield pushing the upper lip forward. It blocks the force from the lip so that there is a clearance between the gingiva, soft tissue, on the upper, so that it inhibits the force from the labial, so that can enhance it breaks the equilibrium, so that the force from the tongue can enhance the maxillary growth. And also there is a lingual wire here, so it prevents the mandible to grow forward. And there is a buccal shield, which is extended to the vestibular area, and it stretches the soft tissue so that it expands the arch, so that it is functional appliance, which is believed to have a orthopedic. So I use this. And see the patient using functional appliance here. And let's see, this is an anecdotal case, so it's very difficult to generalize this idea. But this patient showed lingually inclined upper and labial flare, pretty much classical molar relationship. And this is the patient to begin with. This is the end of the treatment. As we can see here, 8 point, this is the amount of nasal growth of the nasal. This is a lower growth of the ankle. It did not grow more, I guess. I believe. Who knows? So there is no orthopedic effect. The thing is that you can have, there is a shift over here, mandibular shift in the great role. Mandible has been hinged open because the y-axis has been opened up a little bit. So the profile has been increased. So what I can say is that there's a little orthopedic effect. So sometimes I have a class 2 patient and I put class 2 activator to the patient, and 6 months later, the patient's parent came over to my office and, oh doctor, thank you very much. My kid has been, mandible has been grown. So I said, okay, that's maybe perhaps due to the activator. And I asked the patient, did you wear the activator? He said, no, I just put it in my pocket for 6 months. So if you have a Franco 3 and put it in your pocket for 6 months, you can correct the class 3, right? Like the rain dance. So, this is the orthopedic real is, do we have it in real life or is it just a fantasy? Well, perhaps orthodontist wants to believe there is an orthodontic effect, and that's because we want to extend our scope. That's why the American Journal of Orthodontics changed their title to Orthodontic Journal and Orthodontic Vision Orthopedics. And I could say, definitely unanimously, there's an orthopedic effect, and it could be stable. But it's very difficult to extrapolate into human being. It's very difficult for human to do that. Let's move on to contemporary orthodontics. So there are two approaches of protraction headgear. One is to move the whole arch as a main mass, like splitting all the arch in one piece, and put the maxillary investigation here. So it's very difficult to locate the center of resistance of the maxilla, but let's suppose it's somewhere here, and this is the center of resistance of dentition, and the hook is somewhere here. This is fixed. So only the force is applied at the hook. So then if you are to move the whole maxilla forward and downward, force direction should be on this to move the maxilla. And if you are only interested in dentition, force can be applied in this direction. So here's the patient before and after. And you can see that a little bit of the effect maybe. And mostly it's a dental effect. Whole dentition has been translated forward, and lower dentition has been uprighted. This is even though I use the protraction headgear, I do not expect too much orthopedic effect. I mostly expect a dental effect. So if you are to move the dentition only, you can see you can modify the protraction headgear. So that you can see here is an extension arm extended forward, so that if the force is applied here, the force is acting at the center of resistance of the dentition, not the maxilla. So in this case, I use the protraction headgear just to protract the molar forward, and I do not anticipate any orthopedic effect. So here's the patient before and after, and you can see that the treatment was done only by orthodontic treatment, not orthopedic. In last year, when I was in AAO, Dr. Clark, Clark was showing this kind of appliance, showing the pure orthopedic effect. The force is applied only at the exclusive dental movement. So he's insisting that it's a pure orthopedic appliance. And he showed this slide that the mandible has been, both of the mandible has been modified here. And this is the patient before and after what he's shown. However, in some literature, if you put too much force on the condyle, there will be a resorption of it. So you have to be very careful in applying the stress of the condyle backwards. So if he is to flex the mandible, why don't we use the memory wire over here so that we can bend the mandible like this, rather than using a class 3 elastic and pushing the condyle backwards. But it's theoretically, it's not very. I don't think it's possible under the acceptable amount of force. And he claimed that the glenoid foci is also remodeled here. And this is the position of the mandible before and after. This is not the remodeling of the condyle, it's the repositioning of the condyle by modification of the glenoid foci. This is what he claimed, but I think it's very difficult to generalize. Most of the treatment is if I carefully look at this case, most of the treatment result was involved by backward rotation. Here's Dr. Moon's case in an adult patient. How can we he enhanced interstitial growth by applying Marpi in adult patient. So He is one of the most fortunate orthodontists in the world. His patient is so cooperative that he let him wear the mask or she had to. And let's see what happened. Patient before and after. And this is what he used the Markby to mask growth of the maxillary location. And as you can see here, most of the treatment effect was not by, do you see many forward growth? Not that much. Most of the treatment is by mandible injury. And also, he used force level of 1 kilogram or more, like 1.5 kilogram or more. And here's the amount of the maxillary growth by this amount of force. To have 1 millimeter of advancement, you should wear 1 to 2 kilograms, or totally it would be 2 to 3 kilograms on the face mask, or more than like the veneer. And we have to analyze the cost and benefit. Okay? So if you wear the protection head here for a long time and you put too much force on it, you'll definitely have a soreness like this. And this is a time where we should evaluate the risk and the reward that we get. So the time that the patient paid putting on to wear the elastic, and patient compliance, and the patient has to go through an unpredictable result. Even if the patient has been wearing the protection headgear for like 10 years and later on eventually get the orthodontic surgery, don't move to their set. So only thing that we get is orthopedic, a little bit, perhaps a little bit of orthopedic effect, but in the human, I think it's scary. And another approach is from Dr. Lee. He used extraoral alveolar movement. He translated the teeth backwards like this. And you see that the incisors were translated. Symphysis is very narrow. And he showed the X-ray showing that there was a new bone formation on the lingual side. Back in 1919, like 15 years ago, when I visited America, AAO, Nelson was showing a case. She showed a case where labially translating the incisors successfully like this. And here's the patient before and after, and she claims that with appropriate biomechanics, we can translate the lower incisors forward by translation, with bone, so-called. And this is the case in her biomechanics CD. I quoted from her. And you can see that the mandibular incisor has been moved forward quite a lot of and when I was a student, I was quite skeptical about this, and I wrote a letter to Dr. Burston, and is it possible to translate the lower incisor forward? Okay? And what he answered, his answer was a long letter, but the answer was difficult. If you translate the incisor forward, you'll definitely have a recession. Only successful case is because we're lucky. So here's famous injuries, approximately. You see there are a lot of diseases by lateral movement. And in the contemporary textbook, this is a translating of the lower incisor forward. And if you look at the flap up, if you open up the flap, you can see the diseases over here. So to moving the more to the labial side, it's quite difficult. But as Dr. Lee claimed that if the incisor is moving to the lingual side, total volume is increased when you move to the labial side. But if you are moving to the lingual side, the whole volume is maintained so that bone is going to be thicker. So he says it's possible. But we should have to be very careful. I would like to, I don't have much time on biomechanics in class 3. Sorry about this. I'll finish my case by showing you a little bit controversial case here. Here we have a 10-year-old girl. She shows asymmetry and also class 3 relationship. So at the age of 10, the discrepancy was like this, and as she was growing, I did nothing but to wait. She turned out to be 14 years of age, and you can see that the mandible has been deviating much more and more growth. So you can see that there is a compensation. When the mandible shifts or grow more, if it shifts to the left side, upper dentition leaning to the left side, all the lower incisors are leaning to the right side to compensate. Okay? So when we treat this patient, if you inadvertently use a straight wire appliance with pre-adjusted angulation bracket, you're going to decompensate it. So the teeth might end up aligning well, but overall spatial relationship will get worse. Okay? So you have to keep this compensation when you dentally treat this. So only class 3 on the right side. So what I did was asymmetric extraction of the lower and kept the angulation of the cuspid incisors. As you can see here, this is the end of the treatment. You can see that I kept the angulation of the incisor. I did not upright it, so I kept the angulation, and this is the end of the treatment. Still here we have a little bit discrepancy, but I think it's acceptable, and she's happy with the bone. So it's a final. So let's take a summary. So, do I use orthopedic appliance and functional appliance? Yes, I use orthopedic appliance and functional appliance, but I do not expect too much orthopedic. So, can we inhibit the mandibular growth? Well, in animal, yes, but in human being, it's questionable. Can we redirect the growth of the mandible by modifying the ramus? Well, perhaps yes, but it's very difficult and unpredictable in human being. Mandibular fossa remodeling, as Shirley Clark says, well, sometimes yes, but it's questionable. Can we enhance the maxillary growth? Perhaps yes, a little bit more positive than this. If we keep the modification until the growth ceases, we can definitely have more orthopedic effect. Okay? Rather than these kind of effects, I rely most of the treatment on mandibular rotation. So the mandibular shift, and I rely on compensation. And is extra-alveolar movement acceptable? Well, sometimes yes, but we have to be very careful not to move the incisors labial direction. It is very dangerous. But to the lingual direction, perhaps yes. But we have to be very careful. Thank you very much.
How's this presentation? Please give me a I will give you the certification of appreciation. Certification of appreciation. This is to